Hello, my name is David Schiff. I'm a retired Kaiser Permanente physician. I had a right knee replacement performed by an orthopedic surgeon named Dr. Battenberg 20 months ago. I am not very happy with the results of the right knee replacement, and I am getting a revision of the right knee in 4 days, so a brand new surgery. I've learned a lot since the first surgery. I'm not an orthopedic surgeon, so my knowledge is not that of an orthopedic surgeon. There are many things I wish I knew before I got my first knee replacement. There are different approaches to replacing a knee. One is called a mechanical alignment knee, which is what I received. Another is a kinematic alignment knee, which is the type of surgeon I'm going to next. And what's available at some centers in the USA is a custom knee, which is made specifically for the individual patient. So look into those 3 different knees before you get a knee replacement: a mechanical alignment knee, a kinematic alignment knee, and a custom knee replacement. Other things you might look at before you get your knee replaced is what your surgeon's philosophy is about tourniquet time. My surgeon kept a tourniquet on my leg, strangulating the flow of blood, oxygen, and nutrients to the leg for 110 minutes, almost 2 hours. The severity of the muscle pain and cramps I had in the right leg was unbelievable in the few days after the surgery. And I think that's because the muscles were recovering from the tourniquet and the strangulation that occurred for those 110 minutes. Some surgeons use intermittent tourniquet, so they don't have the tourniquet on for very long, so they aren't strangulating the muscles of the legs. And some surgeons, if I understand correctly, don't use a tourniquet at all. Another thing you might look at is what your surgeon's attitude is about the handicap placard authorization. Certainly in the first 3 months after surgery, it would be nice to have that accommodation to be able to park in handicap parking. It would also be nice if your knee doesn't come out well and it's still painful like mine is when I walk, if one could have a handicap placard until one gets one's knee revision, and hopefully make things better. Turns out my surgeon is, my first surgeon was very challenging about getting a handicap placard. He doesn't like to give them out after 6 months because he figures everybody should be better, and he figures that walking should make you better. So why give you a handicap placard? However, when I walk, it's painful, it's dysfunctional, and I get a large effusion in the joint the more I walk. That's called water on the knee, or an effusion in the joint. So I would still like to get a handicap placard until I get the revision and I get better from that. But my surgeon, Dr. Battenberg, was quite challenging about making that happen, which is quite unfortunate, and I think even inhumane. Other things to consider when you get your knee replaced is what material is used for the new implants. There's cobalt chromium, there's titanium, there may be ceramic, but there are choices. And one of the things I learned was that imaging the knee with CT or MRI to find out what's wrong is problematic once you put in those metal implants. The cobalt chromium, which is what I got for the femoral component, is one of the hardest ones to image and see inside of, to see if there's loosening or anything like that. So what is wrong with my knee? I think you've seen me walk a little bit, and I think you can see it's painful. It's great when I can finally get to the shopping cart at Costco, and I can lean on that shopping cart. So when one walks with one's feet kind of on parallel rails. The right foot goes on one rail, although that's awkward for me, I have to toe in with a knee, and the left foot goes on the other rail, and most people walk reasonably smoothly, but for me to keep both feet pointing forward on those two rails is quite awkward. You can see I have to rotate my right femur inward to make my right foot straight forward and back on that right rail. So the way I have been reconstructed as a result of the surgery and rehabilitation, I do what's called out-toeing. My right foot points out to the side, and which means my left foot points inward. Right foot outward, right toe outward, right heel inward. So, whereas normally one walks with both feet on those two rails, that's not tenable for me. It's quite awkward because I have to turn the femur in. So I have to make a choice with the right foot. What is going to land on that right hand rail? Is it the right heel? Is it the right midfoot? Or is it the right forefoot that lands on the right-sided rail? Each of those ways of walking has its advantages and disadvantages. When I keep the heel on the right rail and the left foot travels forward, the takeoff point is always the forefoot. So you take off the right foot and then the left forefoot, and then the right forefoot. But what that causes for me is a very rocking side-to-side gait, which maybe you'll see from back here. So keeping the heel on the right rail while the left foot travels naturally on the left rail, I rock side to side because of the different takeoff points of the forefoot. I mean, my right forefoot is way off to the side, so I rock way back and forth. If I instead walk not with a heel on that rail, but with a forefoot on that rail, on the right-hand rail, so the left foot, whole foot, goes on the left-hand rail, and the right forefoot goes on the right-hand rail, I have to do something called circumducting, which is where the right leg swings around the left leg to get the foot in landing position. So now my right forefoot is on that right-hand rail, and now I don't rock back and forth as much, but this is also a crazy way to walk. Right forefoot on the right-hand rail, left foot totally on the left foot rail. But I don't rock back and forth as much, but there's that crazy circumduction, but I can walk more straight up and down. Neither one is very comfortable. Other things I can show you are when I squat. So if I try to keep both feet pointed forward and I go into a squat, it drives the left knee inward. And you can see that's not very physiologic and it's not super comfortable, but it's the way my leg wants to work since the surgery. Now, you can see my femurs aren't moving symmetrically. If I want my femurs to move symmetrically, I have to point my right foot out to the side, and now I can squat and my femurs move symmetrically, but you'll notice the right lower leg deviates laterally, the right knee is over the floor, it's not over the foot. Here you can see what I should naturally be doing, the knee is over the foot. I showed my surgeon, Dr. Battenberg, this issue. Here you can see the normal left leg. The knee is nicely over the foot when I'm in a lunge position. And you can look how far my right foot points out to the side when I take a comfortable lunge position. When I take a comfortable lunge position on the right side, right leg forward, you can see my left foot is probably pointed more forward than in the left-sided lunge, but in the right-sided lunge, my right knee does not fall over my right foot, and my right foot points more out to the side than one would normally have in a comfortable lunge. But this is the most comfortable lunge I can do because my foot's flat. Dr. Battenberg nicely pointed out that he could make my right knee go over my right foot. He said, look, David, all you need to do is push your knee out to the side and it goes over your foot. He didn't seem to mind that this lunge position would be with my right foot on its side. He said, look, the knee is over the foot. And I thought that was rather silly.